Welcome to Med One Pager. My name is Benjamin, and welcome back to the new series. That is the series about the newborn, or the series about the NICU. So, in this series, we cover different principles to managing neonates and things like that. And this video is going to be about newborn resuscitation, something or a skill that every caregiver who is going to handle a newborn child or a neonate must be well versed with. So I'm not going to pretend to cover the practical aspects of this thing, but I'm going to give you the theoretical knowledge that you need to understand, the different things that you need to keep in mind when you are approaching newborn resuscitation, be it on the ward or during examinations. So these are some of the core principles, and I found that most videos on the internet are not actually on YouTube and not covering these theories in detail, and they focus more on the different practical aspects. So this is going to be the theory, and when we start with the core principles, what you must know is that 90% of all newborns need no intervention. They're going to be born and they're going to be able to breathe on their own, but 10% are going to need assistance to breathe. This can be as simple as using a penguin sucker to clear up secretions, to maybe some backing, and then 1% are going to require extensive resuscitation. Now, one thing that you should appreciate is that different countries have different protocols, but the baseline is always going to be the same. The theories are going to be a bit more of the same. So when you look at the pathophysiology, something that is going to be different from adults is that the primary issue in neonates is failure of aeration of the lungs. And when the neonate is having failure of aeration of the lungs, they're going to go ahead and have hypoxia. And when they suffer hypoxia, they develop bradycardia. Now, in adults, most of the time, the most common cause of resuscitation is actually going to be a cardiac arrest. And you realize that chest compressions are going to be the thing or the area of focus. So we have the golden minute. This is a very important critical concept, and it's like the first 60 seconds are always going to be the decisive window. The aim is to see that is the baby breathing spontaneously or is the baby receiving ventilation. And when you delay ventilation, you're going to have issues arising like brain injury, and things like prolonged resuscitation also increase the chances of this child developing more and more. They're going to develop more and more complications, things like HIE, hypoxic ischemic encephalopathy, and the sort that eventually may lead into the long-term brain injury that develops into cerebral palsy. So we have the initial assessment. You want to ask yourself these three questions when a baby is born. Are they calm? Are they having a good tone? Are they breathing, or are they crying? If yes to all of these, then you want to go ahead and just do the newborn care. They may need to receive the eye ointment and things like that. If no to any of those, then you want to consider resuscitation. Now, the initial steps within the first 30 seconds when you receive a baby, you have to make sure you warm them up, because hypoxia is going to be a very, very great issue when it comes to this baby. They're coming from a warm environment, from a moist environment, and you're exposing them to air. There are obviously going to be some issues. So you want to clear the airway, and then you want to stimulate breathing. You want to provide warmth. That can be with a radiant warmer. Sometimes it can be the GIA. It can be as simple as basically closing the windows to the room and keeping the room warm. You want to clear secretions only if needed, and studies have shown that sometimes as the penguin sucker is pushed into the mouth, it can lead to vagal stimulation that leads into bradycardia, and this can lead to some issues. So you only clear the secretions only when you need to, and clear only the secretions that you see. Sometimes you have situations like meconium aspiration syndrome, whereby there is meconium that is down, and people have tried to maybe do that clearing of that meconium, suctioning it away, but studies have not shown a good outcome. So make sure that you are not going ahead to push the penguin sucker too deep I'm thinking that that will remove secretions that you're not seeing. Then you want to try and stimulate the baby and always reassess the respirations and the heart rate. So when it comes to the heart rate, this is always going to be the most important parameter when it comes to newborn resuscitation. And it is actually a decisive factor. So whenever we have a newborn with a heart rate greater than 100 BPM, we tend to believe they are actually breathing well, because as we saw in the pathophysiology, once they are having hypoxia, they experience bradycardia. So if there is no bradycardia, sometimes we can strongly say that this neonate is having a good breathing. And then we start to ventilate them, because we are aiming at improving aeration, reversing hypoxia, and hoping that that is what is going to bring the heart rate up. But if the heart rate goes below 60, we believe that this unit is not having effective, we shall suspect that this neonate is not having effective circulation, and below 60 beats per minute, we want to begin the chest compressions. Now, always prioritize ventilation over everything else, because as we have seen, as you ventilate this neonate, they are going to improve their heart rate and they will saturate better. So when you're preparing for resuscitation, we have the essential components, that is the anticipation and preparation. If you're having a mother who you suspect is going to be having a difficult labor, in fact, for every delivery, it's important that you prepare to resuscitate the infant. Teamwork is important, and you need more than 2 trained personnel in neonatal resuscitation. As I told you, this is not something that you come out of the books and you're like, I'm ready to resuscitate this neonate. You will absolutely fail. You must have done practical sessions to practice on how you can do this. And effective communication is very important, and working together. Equipment checklist is very important. You need a bag valve mask or the ambu bag, and it should be of the right size. The masks of different sizes. We have the sizes for the preterm, the term, the big baby, and things like that. Suction device is a must, but if it's not there, you need at least something like a penguin sucker or something. An oxygen source is important. Most of the time, we go ahead and put these neonates on CPAP after they have received resuscitation. Then intubation equipment is important. Warm towels, stethoscope, as well as some drugs. And the drugs that we commonly use is going to be epinephrine. So step 1 is going to be warmth. You want to ensure the room temperature is about 25 to 28 degrees Celsius. Dry immediately. Remove wet cloth and cover them with clean, warm linen. Then step 2 is going to be stimulation. You want to rub their back. You want to click and stimulate the source. And then if there is no breathing, you want to proceed. So how do we position the airway? We put them in a supine position with a slight neck extension and a shoulder roll if needed. Sometimes we put or fold a blanket or a small towel and put it under the shoulders. This is going to help lift the head a little bit higher and enable that slight extension of the neck. Remember, neonates have a bigger head than the body. So when they're lying on a flat surface, the head is going to be pushing forward and most of the time obstructing the airway. So this kind of positioning, the sniffing position, is going to help to open up that airway. And then we do the suction. You want to avoid routine suctioning, as I explained. Suction of the mouth and then the nose. And if you go ahead and do a deep suction, you may stimulate the vagus nerve and cause a bradycardia. And you do not want to do that. So ventilation is the most important step. And the indications are going to be if the baby is not breathing or if the heart rate is less than 100. The technique is going to be using a bag valve mask ventilation at a rate of about 40 to 60 times per minute. As you're doing this, you're going to look for the rise of the chest. That is how you will know that you are ventilating those lungs very well with a bag valve mask. If the chest is not rising, then Mr. SOPA comes in. So Mr. SOPA is just an acronym that we use when we are doing positive pressure ventilation and we find that the positive pressure ventilation is not working. So it's a sequential kind of troubleshooting. And the first thing you want to do is the mask adjustment, whereby try to readjust your mask, put it in another position, see if it works. Repositioning the airway, That is going to be maybe check if they're in the sniffing position, is the airway not obstructed. Then suctioning the mouth and the nose. Sometimes you may have maybe secretions that are covering the airway. You want to open the mouth. Then increase the pressure on the positive pressure ventilation. And then lastly, if everything else fails, you want to consider an alternative airway. That can be an endotracheal tube or a laryngeal mask airway. So chest compressions is another one aspect that you have to understand. These are mostly going to be required when you have a heart rate less than 60 beats per minute after 30 seconds of effective positive pressure ventilation. And the technique is you use two thumbs with an encircling method, and the depth should be at least a third of the anteroposterior diameter of the child's chest. So from the top, the sternum, to the back, about a third. Then the ratio is going to be 3:1 to ventilation. So you're going to do 3 compressions, 1, 2, 3, and then press the bag valve mask. That is for the fourth time, for the fourth count. Then 1, 2, 3, 4, you ventilate. And the number of total events is going to be 120 per minute. So you're going to do 9 compressions, 90 compressions, and 30 breaths in 1 minute. So volume expansion sometimes is required, though not routine, and this is when you have suspected hypovolemia or hemorrhage. This may be a case of a child who has had maybe bleeding, maybe the mother had placenta rupture, and the child lost her volume. Now, if you resuscitate and you don't correct the hypovolemia, of course, this child is not going to get better. So some of the fluids that are used, we have normal saline, blood, and the dose is about 10 mils per kg. And this is really similar to what we do in adults. So the advanced airway can be considered if there is ineffective mask ventilation, prolonged positive pressure ventilation, or chest compressions are required. And the options we have the endotracheal tube, which is normally preferred. And if it fails, you can consider using the laryngeal mask airway. So the drugs that we use is epinephrine, and epinephrine is most of the time given via the umbilical cord. Additionally, we can correct hypoglycemia and dextrose. So when you look at the medications, the indications, if the heart rate is less than 60 beats per minute after doing positive pressure ventilation and compression, then you want to start now the epinephrine, and you're going to give it IV. Sometimes it can be given through the endotracheal tube, but IV is being preferred, and you want to use the umbilical vein because it's right there. It's easier to use. The dose is going to be 0.01 to 0.03 milligrams per kg. So when do we stop resuscitation? This is a very important question because you do not want to resuscitate this baby and bring them back and they are brain dead, only to have to put them off life support again. So if there's no heart rate after 10 to 20 minutes despite adequate resuscitation, sometimes you may be forced to stop. And you want to consider the gestational age, the cause of the need for resuscitation. Sometimes the cause may be terminal, and then the resources available. So if there's some one-liners that you need to remember for neonatal resuscitation, is that air goes in before drugs in. Do not rush to go for the drugs. And heart rate is the main primary decision driver. Remember, when the heart rate is greater than 100, most probably this baby is breathing fine. We have the 30-second rule, and you want to resuscitate constantly. Mr. SOPA is something that saves life. It's always sequentially troubleshoot failure of positive pressure ventilation. Compression is only after effective ventilation. So there's a truth I would like to share with you, and that is that neonatal resuscitation is not something that you master without practicing. You can spend hours reading and understanding the theory. And don't get me wrong, the theory is very important. But you will fail to raise the chest of that baby if you have not mastered the skill. And sometimes you may go ahead and do the whole Mr. SOPA, But when the problem is actually that you do not have the skill, you do not know where to place the mask and things like that. So in Uganda, most of the resuscitation is done by nurses, and I would like to extend my gratitude because they have saved a lot of lives. And as a doctor, I encourage you to keep practicing and keep learning the skills. My name is Benjamin, and I am the founder of Mid One Pager. I hope you have learned something from this video. I would like to encourage you to subscribe to the channel because we are going to be sharing more great content. We are going to cover very, very important topics that could help you save more lives and also get better in your career. Let's meet in the next video. Have a nice day.